Thank you for having me to your beautiful country. We're going to talk about aggressive lymphomas to start. These are my disclosures. So in the WHO classification, we'll talk about large cell lymphoma. We'll talk about the distinction between germinal center type and activated B cell type. We'll talk about high-grade B cell lymphoma, including what we call double hit with rearrangements of BCL2 and or BCL6 along with c-MYC. We'll also talk a little bit about primary mediastinal lymphoma. It's a little bit different subtype of large cell. So just a few cases to present along the way to give you examples. This is first case of a 72-year-old woman presented with left-sided chest pain. She had a CT scan, which was negative, looking for a pulmonary embolism, but it did reveal adenopathy throughout the neck, axilla and mediastinum, as you can see on the PET scan. And it showed disease above and below the diaphragm. She had kidney involvement as well as bilateral perfusions with an IPI of 5. So chemotherapy for large cell lymphoma started back in the 1970s with CHOP chemotherapy. This was the first regimen combining chemotherapy agents. As you know, the first chemotherapy was given in Dana-Farber by Dr. Farber back in the 1950s. By the 1970s, we're putting drugs in combination, and CHOP chemotherapy was developed. Cytoxan, adriamycin, prednisone. In the 80s, we tried to change this, add drugs, change schedule, subtract drugs, change doses. Came up with many different regimens, some with great names like Promase, Cytobomb. But unfortunately, once we compared them in a randomized trial in the 90s, compared them to CHOP, they were no better. So we had come back full circle after 20 years of trying to improve upon CHOP and couldn't do so. But along came Rituxan in the late 1990s. This was added to CHOP, and this was reported by Bernard Coiffier in 2002. And finally, for the first time in 30 years, we actually showed improvement in survival over CHOP. International Prognostic Index, as you know, was developed also at Dana-Farber, looking at independent risk factors for how people will do it with large cell lymphoma. Found 5 risk factors, and you know them well: age over 60, advanced stage, more than 1 extranodal site, elevated LDH, and poor performance status. And prior to Rituxan, these were the survival rates ranging from 26 to 73%. Quite a variation depending on how you present based on your IPI. In the Rituxan era, these are much improved. You can see the difference that Rituxan has made, particularly in the high-risk patients with 4-year overall survival now 55% compared to 26% prior to Rituxan. So some success. But how can we do even better? And that's what we've been trying to do ever since. Can we identify patients that are at higher risk of relapse, even beyond the IPI, based on molecular subtyping? And can we find more effective regimens, or intensified regimens better? Can we use genomics to separate out patients to figure out who might benefit from different therapies? And what about immunotherapy, the new kid on the block? So we'll talk about some of these things. So this is gene expression profiling. This was first done by a number of groups, including Margaret Shipp at Dana-Farber. and we're able to separate out, based on gene profiling, different subgroups. Two different main subgroups, ABC, activated B cell type, and GCB, germinal center B cell type. And these have very different gene profile expression. And then on the far right is primary mediastinal B cell lymphoma. And that shows how it is much different in its genetic profiling. We'll talk about that toward the end of the lecture, about how it has a lot of overlap actually with Hodgkin's lymphoma, particularly non-sclerosing subtype, and how it's a very somewhat different subgroup. So this is survival based on these different gene profiling. As you can see, the germinal center B cell group does much better than the activated B cell type. This was published over 10 years ago now. Though it's very hard to get gene profiling on a patient. It's hard for us to do that back in the States. I imagine it's not that easy here either. So instead, we can separate out these groups fairly well based on immunoperoxidase staining on biopsy samples. This is known as the Holmes criteria. And you can see that if you're CD10 positive, you're a germinal center type. If BCL6 is negative, you're not a BCL type, non-germinal center type. And if it's positive and you look at MUM1, MUM1's positive in the non-germinal center type and negative in the germinal center type. So you can use these three immunoperoxidase studies to separate the patients out into these two groups. The question is, does it do us any good? Because how do we treat them differently? Well, we started by using more aggressive regimens, maybe using them more often. So on the left is R-CHOP chemotherapy given Q14 versus Q21 days. And we can see that doing it with a closer interval made no difference. Survival is exactly the same. On the right was a phase 2 trial of dose-adjusted R-EPOCH, and the failure-free survival at 81% at 5 years was looking good. So we were encouraged by this regimen. So there was a phase 3 trial. And I think that there's a couple things to learn from this. One, well, there's no difference. But I think it also tells you a lot about clinical trials in which phase 3 results don't always equal phase 2 results. You know, phase 2, the patients are more highly selected. Phase 3 is more of a real-world kind of collection of patients. So I think that teaches us about different phase trials and the importance of doing phase 3 trials. I think the other thing to get out of this, obviously the survival was the same. And we're going to be looking, or it's being looked at based on molecular subtype, looking at double hits, etc., to see if we can get some more information out of this. One thing from this trial, though, is that there were very few patients that had high-risk disease. And so because of that, patients that have, and we'll talk about double-hit lymphomas tend to have high-risk disease. They tend to present with higher IPIs and more aggressive disease. So we're not overly represented. They're actually underrepresented in this trial if we're trying to piece out if dose-adjusted R-EPOCH makes any difference for that higher-risk group with the double hits. So here's the IPI in the trial. You can see IPIs of 3 to 5 was only a third of the patients. So what else can we do? What else can we target in large cell lymphoma? And there have been a number of trials looking at adding different drugs to the CHOP backbone. Rituxan obviously was a success, a big success. There are other things that we can target. So ibrutinib targeting BTK, for example, and then that's been looked at, a randomized trial, particularly an activated B cell type, in which patients received R-CHOP plus or minus ibrutinib, no difference there. Lenalidomide, which works the NF-kappa B pathway and other different pathways, and that's been looked at, adding that to R-CHOP, and we'll look at a slide for that. And we'll talk about some other newer drugs, other new attempts to try to improve upon R-CHOP. So in the past, Velcade was tried, bortezomib, and unfortunately, as you can see, the curves were very similar. So thumbs down on that one. Ibrutinib, this is what we have the data thus far. Unfortunately, in a randomized trial, thumbs down again. Lenalidomide, R-CHOP versus R-CHOP and lenalidomide at 15 milligrams, days 1 through 14. And that was also, unfortunately, a thumbs down. We just completed our involvement in a randomized trial of Polarix. Polarix is an anti-CD29A antibody that obviously binds to B cells, and on the other end is MMAE, which is the agent that's used in brentuximab. So this is a very similar agent, and so the trial, initial early phase trial was polatuzumab plus R-CHIP, because they both cause neuropathy, vincristine and brentuximab. Vincristine was taken out, polatuzumab was substituted because it had a similar neuropathic tendency, just like brentuximab. Initial response rates and CR rates of FISH first trial look very good. So randomized trial was just completed, and we took part ourselves. Patients seemed to tolerate this drug well. Neuropathy did not seem to be overwhelming in my experience. I had a number of patients in the trial. And I don't have results from this as yet, so fingers crossed. Will this do better than bortezomib, lenalidomide, ibrutinib? Will it be adding something since Rituxan? One thing to talk about is central nervous system involvement. That's always a concern with large cell lymphoma. What patients are at risk? And one of the biggest individual risk factors is kidney or adrenal involvement. And so this must be kept in mind. And so this was actually looked at, and there's a study looking at risk factors for developing central nervous system involvement. And looking at the risk factors, pretty much turned out that all the IPI, the International Prognostic Index factors, were important as far as increasing your risk for central nervous system involvement, as well as kidney involvement. So this developed 6 factors, as you can see here on the right, including the standard IPI factors. And if you look at these curves, this is the likelihood of central nervous system involvement based on the number of risk factors. So the gray is 0 to 1, yellow 2 to 3, and blue 4 to 6. So where are you going to put your money as far as prophylaxis goes? Obviously in the blue group. So for patients with more than 3 risk factors, we consider central nervous system prophylaxis for those patients. There are certain site-specific regions also that need to be considered. Kidney, adrenal gland is on here for sure. Testicular is certainly a high-risk group. Uterine, ovarian seems to be controversial. Breast, controversial, but most of us feel that is a site of increased risk. And epidural involvement, you think of as being a risk because it's right next to the central nervous system, but that's not been proven in any individual study. How well does that dura keep disease out? Makes you worried when you get epidural disease. The other place that makes you worried is deep sinus, ethmoid sinus disease, again, because you're so close to the CNS. And that hasn't been proven in any individual study. There's just not large numbers of those to really look at to see if they're individually risk factors, but you don't want to think about central nervous system prophylaxis for those patients. With these sites, high CNS IPIs, for sure. So options for CNS prophylaxis. So, all right, let's look at all the randomized trials of CNS prophylaxis, one versus another. Okay, well, there aren't any. All right, we'll look at randomized trials of plus or minus CNS prophylaxis. Okay, there aren't any. So what have we got? Intrathecal chemotherapy. This was looked at in a couple different papers. The trouble that we have sort of teleologically with this, or thinking about it, is that how does chemotherapy given into the spinal fluid get into the brain parenchyma? How does that really prevent disease there? Can it prevent leptomeningeal disease but not brain parenchymal disease? Interestingly, the only paper that we have that was really well done looking at CNS prophylaxis in testicular lymphoma. So in testicular lymphomas prior, so in the old days, CNS relapse was about 40% without CNS prophylaxis. It was also prior to Rituxan, and it's quite possible that that relapse rate has been reduced simply by Rituxan. But the one trial that looked at giving CNS prophylaxis used intrathecal chemotherapy, 4 doses. There was no brain parenchymal penetrating therapy in that, and it showed to be very effective at limiting CNS relapse in testicular lymphoma. So between the addition of Rituxan and intrathecal therapy, we see good benefit, at least in that one setting. The other way to give this is with systemic methotrexate. Obviously, an old drug, inexpensive drug, a little hard to give is one of the problems with it. In many settings, depending on your hospital, you have to be able to give methotrexate levels. So as you know, you have to alkalize the urine, you get the urine to the proper pH, you give the methotrexate, you have to follow levels of methotrexate until cleared, along with giving, again, sodium bicarbonate, IV fluids, and leucoborin or folinic acid. So it's much more labor intensive. Usually it takes about 3 days in the hospital, whereas an intrathecal therapy obviously can be done in the clinic much more easily. And there's been no trials comparing the two side by side. So I can't prove that systemic methotrexate is better. We tend to use it more often because, again, we think we get brain parenchymal penetration. We think it's better. There's no data to prove that it is. Depends on what assets you have available. For example, just to give an example, if we have an older patient, let's say with some renal insufficiency, we'll use intrathecal chemotherapy. I'm not going to risk further renal damage in a patient with high-dose methotrexate. So that's an example, even when you're not limited by methotrexate levels, etc. As far as the elderly, speaking about the elderly, there is a paper of mini RCHOP. Just to review that, what do you do with your 82-year-old who's a good performance status, you think can still be a candidate for chemotherapy, but concerned about giving full-dose chemotherapy? Mini RCHOP has a very reasonable survival. It's not in a randomized setting at all, but about a 50% survival here at 3+ years is not bad, considering you're dealing with elderly patients that may have other comorbidities. So mini RCHOP is half dose of Cytoxan, Adriamycin, and Kristen essentially, but has a reasonable outcome in older patients. All right, so in case 1, the patient had 6 cycles of RCHOP chemotherapy, got Neulasta support, received 2 doses of systemic methotrexate, refused cycle 3, and she remains in remission actually further than this now post-therapy. So what else can we do? We looked at trying to add things to RCHOP. What about after RCHOP? As you know, Rituxan maintenance or prolonged therapy with Rituxan, most schedules now given every 2 months for 2 to 3 years, depending on the type of lymphoma. This has been looked at in large cell lymphoma and found to have no benefit. As you know, it's used in follicular lymphoma, mantle cell lymphoma, and others. And the rationale for the every 2 months, just to review that, is that once you get levels in the system, usually with weekly ×4 or with combination therapy, it takes 8 weeks to clear Rituxan to levels lower than what is therapeutically beneficial. So that's the reason for every 8 weeks in the other maintenance trials. We don't have time to talk about follicular lymphoma, mantle cell lymphoma. I'd be glad to come back to your beautiful country to do that. Lenalidomide was looked at again in combination, but also in maintenance therapy, again, but not found to have an overall survival advantage. High-dose chemotherapy, autologous stem cell transplant, as you know, that's utilized. It's been the main therapy for patients that relapse with large cell lymphoma. And this has been looked at and said, well, if it works in relapse, how about if we transplant at least high-risk patients in first remission and see if that makes a difference? And unfortunately, the trials have not shown a benefit to that. That may be that we're not picking out the most beneficial patients. So is there an advantage to doing it before they relapse or just wait for them to relapse? So no evidence in intensified regimens or stem cell transplant has helped us. Seen as prophylaxis, we talked about GCB subtype has better outcomes than non-GCB, and there are ongoing trials of looking at newer agents such as polarase. Case 2, 52-year-old patient presents with an adenopathy with bulky disease within the abdomen. Biopsy shows that this is a large cell lymphoma, and this is a double hit. So we'll talk about double hit. So what double hit is, just to review, so you can look for c-MYC, you can look for BCL2 and BCL6 in 2 different ways. As you know, you can look from immunoperoxidase, and you can look by FISH rearrangement. And so the rearrangement seems to be more reliable in sort of separating out the worst prognostic group, which we call the double hits. So those that have FISH rearrangement for MYC and BCL2 or BCL6 are in the double hit group. The group that have both by immunoperoxidase but not by FISH rearrangement we call double expressive. And we'll talk about these 2 groups. So MYC and BCL2 or BCL6 double hit only makes up maybe 10% of lymphomas. So a lot of attention to a small percentage, but this is the group that has the worst prognosis and hence the attention that it's gotten. Histologically, large cell lymphoma on the left, double hit on the right. It looks like a more aggressive histology. And here are some of the features of double hit lymphoma. It tends to present, as I said earlier, with more aggressive disease, more advanced stage disease, more sites that are extranodal, higher Ki-67 index. Most of these are GCB subtype, which is interesting because GCB does better than activated B cell type. But again, it's a small percentage of GCB, so it hasn't brought down the whole GCB group. But if you have a large cell lymphoma, it's activated B cell type, you can't get FISH rearrangement, it's probably not a double hit because most are GCB subtype. So intensive chemotherapy, we've seen improved progression-free survival, at least initially in this paper from Petrick et al. Didn't look to find significant overall survival in these patients, and maybe because you can salvage some with auto transplant. And so the question is whether intensified regimens are better. He also looked at upfront autologous stem cell transplant. So across the board in large cell lymphoma, it wasn't a benefit. What about in double hit lymphomas? And again, upfront transplant and first remission was not found to have a difference. This is the overall survival curve on the far right. So, however, dose-adjusted REPAC was looked at in a single-arm trial. This is from Dunleavy, and this looks at both MYC rearranged and MYC with BCL2, but showing encouraging curves, at least with dose-adjusted REPAC. Is there a randomized trial that shows that dose-adjusted REPAC is better in double-hit lymphoma? No. So in general, you get improved progression-free survival with more aggressive regimens, and overall survival seems to be encouraging in single-arm trials. So we tend to use dose-adjusted REPAC for double-hit lymphomas. As you know, it's a much more labor-intensive therapy, 96-hour continuous infusion, usually done in the hospital. It can be done with pumps as an outpatient, but that is difficult. But it's 6 days in the hospital rather than 1 day in the clinic of giving your chemotherapy. But we do think that it leads to better outcomes. This is outcomes based on PET scanning. So the lower curve is patients with interim positive PETs, and the better curve with a negative PET. So certainly a PET scan is encouraging. It's not, as we've seen, the be-all and end-all, in that if you look at Hodgkin's disease, PET scanning after 2 cycles is very predictive of outcome. And now there are many trials of changing therapy, looking at changing therapy based on PET scanning after 2 cycles. Whereas in large cell lymphoma, even with double hits, we don't have that proof. If you've got a blatantly positive scan at halfway through, then that's one thing. If you've got a little bit of activity in a prior site of disease, is that something that's going to get better with time? These are sometimes hard to interpret, harder than Hodgkin's disease. So I talked about overexpression, the double expressors versus those that have FISH rearrangement. So this is positive by immunoperoxidase, but not by FISH rearrangement. And this slide shows that these patients do have a worse outcome based on the double expression. And these are several different papers looking at mostly RCHOP and showing that there is an adverse outcome based on double expression. And here's the frequency. Around a quarter of patients are double expressors. And the problem is that we haven't found a better way to treat the double expressors. Again, no randomized trials really looking at it in depth. We haven't found that transplant works in that group either. Whether more aggressive regimens can work in a selected subgroup, that's something that we have to work on. So the case 2 patient was treated with dose-adjusted REPOC, as we tend to do. They got systemic methotrexate because with an IPI-5, they're high risk of central nervous system involvement. And after 3 cycles, had a mixed response with some areas actually new disease with subcutaneous lesions. She was treated with salvage chemotherapy. She got RDHAP and had progression of disease, had RICE chemotherapy with some response, but again progressed. So what do you do for those? These patients have a dismal outcome. They're refractory to upfront therapy. You can see the survival curve with a median survival of 8 months. There we go. So this is just showing how primary refractory and refractory to second-line therapy is poor outcomes. So what do you do for those patients? You refer them to your transplant center if you have CAR T cell therapy available. Dr. Jacobson is going to talk about CAR T next. It's exciting new therapy, and this is an example of a patient to show just how exciting it is. Her median survival was 8 months, and here she is disease-free 24 months later. So double hit lymphomas, true rearrangements, they're less than 10% of RCHOP, and they have poor outcomes. Intensified regimens may be helpful, such as dose-adjusted REPOC. Double expressors have worse outcome. What to do with them, we're not really sure. CAR T cell therapy is encouraging for refractory patients. Case 3. So this is a young woman that presents with a cough, dyspnea on exertion. She had a chest x-ray, which revealed a large mediastinal mass. She had a biopsy. And it showed, you can see some of the fibrosis you see in patients with mediastinal large cell lymphoma. You can see the sclerotic component is obvious. And this is, again, a CD20 positive large B-cell lymphoma. You tend to see weak staining for CD30, and other stainings such as CREL and TRAF help us to separate it out. And there's her PET scan. So this only makes up about 7% of large cell lymphomas, but it's a distinct subgroup. More common in women, particularly in their 30s. SVC syndrome is common. Pleural and pericardial effusions are also common. And B symptoms are often common. So this is a gene expression profiling, and it just shows that this subtype is very similar to nodule sclerosing Hodgkin's disease. And interestingly, it presents clinically in a similar pattern. Again, it's young people, more common in women for both subtypes. Present with anterior mediastinal masses, both have sclerosis, both can have CD30, though much more in Hodgkin's disease, and they both have abnormalities at 2P and 9P that can be isolated. So, what do these patients respond differently? Here are 2 studies, one from the NCI and one from Stanford, with event-free survival on the left, overall survival on the right, looking at dose-adjusted REPOC, and the curves are quite excellent. So at least in our practice, we now use dose-adjusted REPOC rather than RCHOP. In the past, we used RCHOP with radiation, and RCHOP with radiation has very good outcomes also. It's just that you're also able to avoid radiation in what's usually young women with risk of breast cancer down the line. This is when this was taken to multi-center, and the survival was still pretty good. It wasn't quite as good as the single center, which is always the way it tends to be, but still very good outcomes with dose-adjusted EPOC. This is outcome by end of therapy PET scan. Again, showing a positive PET scan at the end of therapy is worrisome, with quite a difference in survival. So what do you do for those patients? Just a word about that. 26 seconds left. Pembrolizumab is now approved for relapsed refractory primary mediastinal large B-cell lymphoma. Its activity is not surprising because, as you know, this is a very active agent in Hodgkin's disease, and these two entities are very similar genetically. And so I have a patient who was not a transplant candidate who was refractory to 2 chemotherapy regimens, high-dose radiation, got pembrolizumab, and she's been in complete remission now for 2.5 years. So it's encouraging that it may actually be curative for a subgroup. These are just waterfall plots. And just a word on PET scans at the end. I said it's a bad thing, right? Well, this is her end of treatment PET scan, and this is 3 months later. Because you do have a large mass, it's scarring down, you're going to get inflammation. Be careful about interpreting end of therapy scans in patients with bulky disease. So again, it's a heterogeneous disease, and we're separating out more subgroups all the time. Upfront therapy with R-CHOP is the standard for us, except for double hit lymphomas and primary mediastinal, where we use dose-adjusted R-EPOC. Still looking at novel drugs. We're hoping Polarix will be effective. We'll see if we can find anything better. CAR T-cell therapy is promising, and that's the lead into the next talk.